Mehmet, welcome to the show. Thank you for being here.
Thanks for having me. I'm pleased, and I was a few minutes late, people. I was a few minutes late, and I've managed to just about make it. So thanks for the invite. Looking forward to diving into having a chat. Yeah, thanks for having me.
Yes, and we are going to dive right in. In fact, to talk about some of the misinformation out there about the causes for hip pain. I'm sure you've heard this and I've heard this, but also some of our patients about asymmetries, labral tears, popping, clicking hips, etc. So please enlighten us about what is it that we should really be believing when it comes to hip pain.
Where do we start, Susie? Where do we start? I mean, we're going to be here all day, but look, I think a lot of the stuff. Look, we met through social media. Obviously, you reached out through that, and that's my avenue to try to share things on online that's decent information. I think the problem with information online is it can get diluted by people who probably don't know as much about stuff. Like, I by no means know everything. I've been a physio for 15 years and specialized in a decade in this stuff, and I still don't feel like I know anything. So I think when there's a lot of people giving advice, sometimes patients get confused. And
Mhm.
unfortunately, the thing on social media and online is that patients are being told like really simple things to cause their hip pain, and it's never that straightforward. Like, the human body it's not a car. It's not like something is broken and we'll go and fix it, or you can have an MOT or whatever. Like, it's such a complex system of like the brain, the nervous system, psychology, physiology. So my biggest bugbear really is when I see patients and people online or whatever it might be, really trying to ascertain hip pain because of a tight muscle, or because
Mm.
something is a little bit weak, or because the asymmetry stuff bugs me. I'm like, we're all asymmetrical. Why is it just like all of a sudden for some people it's relevant? So I've got that balance of like the passion of what I'm trying to put across, and then not being rude. Like, I don't like being an account who is just jabbing people online or whatever. I'm not really about that. But also, it's frustrating because I have to kind of rein it in sometimes. Because I actually, like, people read this and they're quite desperate for help, and none of
Yeah.
it is true. So yeah, in regards to kind of the stuff that could cause it, there's so many different types of hip pathologies, but it's just about trying to navigate that. Often you just need the right person to help you understand really what might be going on, with hip pain, really.
Yes, thank you so much for sharing that because you're right. There is often people are very desperate to get help. And in a world where we have so much information readily available at our fingertips, it's often that folks do get confused. And frankly, there is no, unless you know how to sniff out bullshit, you wouldn't know otherwise. And so I think it's a huge disservice when we really are myopically looking at a situation that actually is quite complex as
Mm.
far as hip pain or that connects to the pelvis. I often tell people that, your hip and your pelvis and your lower back and everything else is all connected, including your brain, your environment, your context, as you mentioned. So let's go back to some of the misinformation and stuff that's circulating out there as far as maybe pelvic tilting is something that I usually hear a lot as far as anterior pelvic tilt or posterior pelvic tilt as a cause for hip pain or low back pain or pelvic pain for that matter. Can you speak a little bit about the pelvic tilting?
The pelvic tilt in Susie. This, honestly, like, if I could write like what is the bane of my life, there's the top three, and I say this is up there. This is sometimes the top one, sometimes it's two or three. It's always there or thereabouts, because that is one of those things that is almost like bastardized to the point where people are
Mm.
like, well, look, if you have it, that's the cause of your pain.
Mhm.
Look, for some people, there is some occasions where it is relevant, but even when it is relevant, you're like, it's never relevant in isolation. But unfortunately, there's a narrative where someone has a pelvic tilt, it will give them back pain, it will give them hip pain, go away and do this stretch, or go away and do this exercise, and it will somehow change it. The human body has variations, and that changes from gender to ethnicity to all sorts, and that will also be present in those who with their pelvic positions and tilts and angles.
Mhm.
That will then mean that for some, what seems excessive is actually normal, and for others the contrary. Now, unfortunately, there's also then that dialogue of, well, actually, this is a quick fix. You go and do this, and it's going to
Right.
get rid of your pelvic tilt. You go and do that. And for some, and it's always the ones who seem to be shouting the loudest, unfortunately, on online, for some it can help, but it's the conversation is sort of, well, actually, is it that's helping? Is it
Right.
just the fact that you're getting someone active and moving? Is it the fact that you're re-educating and reassuring them, and actually that's the most important element of what you're doing? But unfortunately for me, like, it's a big bugbear, because when you have a certain pelvic tilt position, if let's say the common one is, an anterior pelvic tilt, that's what everyone finds is the sexy topic of pelvic tilts, which I never knew there was a topic of pelvic tilting that could be sexy. Apparently there is now. But that for many people is fine, doesn't cause an issue,
Right.
asymptomatic, isn't even a problem at all. But are being told, well, if you stretch this, if you strengthen that, it's going to change the position, and it won't. Right?
Mm-hmm.
Just because it's on a picture, because someone's posted their before and after and it looks a bit different, don't be kind of fooled. Don't be fooled. Actually, what you have to do is look at proper evidence-based literature and research and see, well, even in populations where you are doing repeated long-term static stretching for hamstrings or hip flexors or whatever it might be, you might see a change for an hour, but it's not going to change it consistently, and it certainly isn't going to be the fundamental reason why that individual has pain. But unfortunately, when that conversation happens, it trivializes that person's
Mm-hmm.
experience of pain. And when it doesn't work or last, then that patient is then left with thinking, I've got a pelvic tilt issue and I can't fix it. What do
Yeah.
I do next? And then they go
Mhm.
to the next person, and then they dig their thumbs into whatever or try to release whatever it might be, and then that doesn't work. And then often a lot of my caseload are patients with quite complex hip issues that have seen all these different people and given these little bits of advice, and that's frustrating for me, and also, but primarily just because it doesn't support the patient's recovery at all.
Absolutely. And it's quite fear mongering, and also just saying you're broken. You're broken.
Yeah.
And if it doesn't fix this way, or if you don't notice it in this particular way as how your body, looks or feels, then there's no
So true. And
fixing.
you know what, Susie? The other thing as well is, like, when you then got like such an extreme
Mm-hmm.
thing here where it's just like, you've got pelvic tilt, you've got an anterior pelvic tilt, that's the cause of your pain, and it's almost like that real negative connotation around it. Then they come and see me, and it's like, so, like, the opposite.
Opposite.
But then I'm like, actually, it almost sounds like I don't give a shit, because I'm just like brushing it off so much. I'm
Yeah.
like, actually, I need to
Yeah.
show that it's not that I'm disregarding your problem or your pain. It's just that
Mm-hmm.
that ain't relevant. Like, that's not, like, it might be in certain situations part of the
Mm-hmm.
picture, but it's not the only cause of it. But you can only do what you can do,
It's a
when you're a
delicate
clinician.
balance, right? I've heard that Marty Smith is an occupational therapist, and I was just on an OT pelvic health conference, and she said something that really stuck with me, is match the cadence, but not the dysfunction. When you're working with someone, right? Meet them where they're at, but don't get enmeshed with the dysfunction. And this
Yeah.
is just totally hitting home our conversation about that. It's like we need to meet them where they're at as far as their knowledge, what they feel is going on,
Yeah.
and also trying to dismantle little by little some of this misinformation or these beliefs, which we know play a role in how we feel about our bodies and even our recovery process, because beliefs, thoughts, feelings, etc., what we're told, our environment, context, all of that are physical processes, right? Like we kind of almost disregard those as potential factors, but you and I know that
That's the thing.
those factors are huge.
I know. And that's the problem. And I think often where patients don't benefit, for those patients who are listening, and also clinicians, there's no value in, even if I had someone who came to see me who said to me, oh, I've been told all this stuff, like, are you sure it's not that I need to be doing? Like, even then, when I think, geez, you've been told so much shite, like, none of that even makes sense, I'm still not going to tell them that. I'm still going to be
Right.
like, oh, okay, cool, well, it didn't work. Because, like, you as a clinician, us as a clinicians, like, the number one thing that we need to try and do with our patients is build a trusting relationship and rapport. For me, I feel like that's paramount. That's almost like number one. if you then start that relationship by slating someone else, it
Mm-hmm.
makes it kind of dampens your credibility from my perspective a little
Yeah.
bit. So even when I'm in my head, I'm like crying in my brain, and my
Right.
inner monologue is like, what? In reality, I'm just like, oh, okay, cool. Well, let's not work. Let's try something else and do
Yeah.
something like slightly different. And
Yeah.
they benefit from that better.
Absolutely. Absolutely. Let's move to scans. So the topic around labral tears, hip labral tears. I know a lot of my patients, even in the pelvic health world, because again, it's all connected. Labral tears are often blamed for pelvic dysfunction, pelvic pain, again, hip pain, etc. Help us unpack labral tears. What are they? What happens if
Mm.
you do see it on the scan? Yeah.
So labral tears, I think people are far more aware of them. So the labrum is potentially, for those who have hip pain, a nociceptive source, a painful source within the hip joint. There are certain factors that may lead to someone having a labral tear, but there's always that ambiguity in regards to, well, is that the thing that's actually even causing their pain? If we kind of like go into first maybe some of the causes that may lead to it, then I'll circle back and reaffirm why even at that point you need to kind of critique and question its relevance, even if it is the problem. Now, the labrum doesn't necessarily, as a structure, just randomly tear. If we're talking about young active individual, young active adult, we're not going to just develop a painful symptomatic labral tear just spontaneously having not done something. There's often a cause, and two of the common causes of that would be FAI syndrome, so femoroacetabular impingement syndrome, and hip dysplasia. Two of the probably most like common causes, hip pathologies that would lead to a labral tear. The complexity around those two things come with their own issues, and also they coexist, which is a different conversation. But nonetheless, if you have a hip with either of those two characteristics, one would potentially be a shallower socket for those who have hip dysplasia. Others with, let's say, a cam morphology from FAI syndrome may have an impinging type hip that could cause a labral tear. Both of those in different ways can cause that to develop. Now, at that point, even if you then have a patient who has FAI syndrome or dysplasia or a labral tear, it then brings up that conversation, like I said before, the ambiguity around, is that actually the thing that's causing the pain? Because one, people have FAI syndrome or characteristics of it and have no pain. People
Mm-hmm.
have hip dysplasia and manage well. If you look at ballet dancers and elite dancers, have a degree of laxity or hip dysplasia, and actually are desirable for them. And equally, those who have labral tears, 50-60% of us will have it and never know. So
Mm-hmm.
even when you know and you think you still have to question if you really know, because that's the difficulty here. And unfortunately, when you have on paper labral tear, let's go and have surgery to operate on it, because it's like black and white. It's almost like
Right.
the extreme version of the pelvic tilt, right? It's like, oh, well, this is broken, let's go fix it. And
Right.
then they don't get better. You're like, well, actually, was it that? Was it something? Was it your back? Was it something else? Was it like pelvic floor related? Was it viscerogenic? All these different things really should be the fundamental first thing that you're thinking about. And when I'm with my patients, even when I teach, I'm thinking, look, this is what it could be. Like, try and refute as much of the other stuff as much as possible. And then if you're left with that, then you're thinking, well, it could be that. And then you treat as you would do. But unfortunately, and it's probably like more prevalent, I'd say, nowadays, patients just want a scan, because if they get a scan, then they know what the problem is.
Mm-hmm.
But it's a difficult conversation, and also it's almost like more helpful when patients don't have access to some of these scans immediately, because they don't have those expectations. But if you've got private healthcare, then you're like, right, I want a scan, let me go and see whoever, because then you can treat it. And I'm like, no, we can treat it without the scan. We can manage. Don't worry. We don't
Right.
need the scan every time. But it's just like the joy of managing patient expectations is never a
Mm.
direct, simple road, though, right?
Oh, so do you find that those who have that scan, that confirmation that there's a tear, there's something here, versus those that don't have the scan, like in your clinical experience, compare and contrast those for me. Who which one of those actually may perhaps do a little bit better? I'm biased here. I'm fishing for the answer.
No, but
I'll
the
be
thing
honest,
is,
I'm biased.
it's interesting. It's interesting though, because if you've got a patient who has had the scan, right,
Yeah.
and they come to see and they're like, well, look, I've had X-rays, MRIs, and I've got this and this. Often they'll then turn around and say, it depends how they've got to you, obviously. If someone's referred them, if they've come under duress, which not many people do, they kind of want to come and see us. But let's say they're in our room. Then I turn around and say, well, like, how are you going to fix my labral tear? Because the labrum's torn and I've got a bony bump because of my FAI syndrome. Why are you giving me like squats and deadlifts and lunges? Because like that's not going to help. And then you're like, well, I'm trying to explain that actually we still don't know even if the surgery is the right option long term.
Right.
But this is the stuff that we control. This is the stuff that actually may well enable you to physically be a bit more robust, physically be a bit more resilient to the activity and load that you want to put through the hip. And also, you may have had this scan result 10 years ago if you scanned it, and you would never have known. But it's only when you start taking the pictures and you start seeing, well, actually, things inside your body also change. You know, I don't always had a white beard. You can't see it too much on camera, but I have got some white beard there, right? And you can see that. And you can just see that's just as you age and you grow older, things change. You know, people get wrinkles, people get grey hairs, but they also have changes to their joints and the internal kind of system as well. But like until you get that scan, you don't know about it. And I'm a big believer, right? Like I'm not against scans. I think the problem is like when a scan is then like the way it's interpreted, the way it's relayed to a patient. So if you're with an individual like yourself or someone who's experienced, and you can say, oh, look, I kind of trust that that's being relayed on in the right manner, and the patient's getting the right information. The problem is when they're told, like, oh, actually, you've got FAI syndrome, I'd go and have surgery because you'll need a hip replacement if you don't, because it will cause it. Do you know what I mean? And then you're like, well, we'll pick the bones out of that. You know, that's the tough one to kind of navigate. Does that fit your bias? Is that what you were thinking?
Definitely.
Yeah, oh, good. Oh,
Definitely
that'd be an
does.
awkward podcast if we were clashing.
I know. And no, it does fit my bias because you're right. It's not the scan that's the issue. It's the narrative around the scan that could be helpful to the individual or harmful to the individual, and also their recovery and how they perceive their own body and their own resilience. You know, that can really
Definitely.
be damaging. And at that point, I mean, no amount of surgery is going to ever take away that seed that was planted of you're broken, you're not enough, your body is not fit for purpose, and forever having to be afraid to even access perhaps the potential that that person might have.
Yeah, definitely. And I think with pelvic pain patients and with men's health, women's health, and with hip patients in particular, I do feel, and you know, I've not seen just hips my whole career. I've seen everything, and there is definitely that similar cohort to lower back pain patients, where there's that slight increase in prevalence of like anxiety, catastrophization, you know, like self-efficacy issues that you'll come across, and all of those things, when considered, can sometimes be negatively impacted by the wrong management, by the wrong person. And often, if you then just manage it correctly with fairly simple but like directed guidance, things can change. So yeah, it's just the right place at the right time, really, for some patients with that stuff.
It is, absolutely. Absolutely. Another interesting conversation around muscles firing or not firing. Something that I see prevalent, I'm sure you do as well, of my glutes just aren't firing, or my core is weak, or etc. Or my IT band is too tight. Can we
Yeah,
can you share a little bit about your experience with that, and what does the literature really say?
so we started off with number one on my bugbear list of all, like, Hall of Famers. Now we're on to number two, which is great, which is kind of muscles. And look, the thing is, whenever I try and kind of dive into this on any kind of social media platform, I then always get kickback from like anyone. It could be clinicians or patients as well, and they'll say, oh, you know, that's not what people mean. They don't mean that it's not firing. I guess, like, just to kind of clarify, the thing that we're talking about here is often my glutes aren't switched on. Gluteal amnesia, which was coined by, you know, some, I won't name drop, but someone, you know, so historically has got like a reputation for back pain, and tried to associate those two, which we know is flawed completely. And then also things like muscle tightness, or, you know, like you said with the IT band as well. Now, ultimately, there are going to be patients and instances where someone will have underactivity. You know, if you have someone who's had hip surgery, as an example, there are going to be muscles that aren't working as well. That's just part and parcel of it. You're also going to have individuals who, from a sporting environment, might not be utilizing movement patterns in the right way, but nonetheless, it's still, the muscles aren't inactive. I think it's really kind of a difficult scenario to be discussing something that is inactive or underactive, or with amnesia, whatever you want to call it. But unfortunately, when you start trying to fix that narrative, then it's like, oh, it's just semantics. They don't mean that. Actually, it's just a case of that they mean it's a bit under. Well, that's the different story, though. You know, things, muscles can't be switched off unless you're dead, or like if you have some degree of paralysis, which happens. But that's such a different level of like insight. It's a completely different pathological course of those things. You know, if you have any kind of neurological cause that drives it, then then you're dealing with something that's really is probably not like firing, and you have that ability to kind of address that. But from a musculoskeletal perspective, when you're assessing somebody, especially those who have hip pain, we often give exercises, strengthening exercises in particular, makes the forefront of most of our kind of management tools. And then the question is, well, like when we do that, why are we doing that? Because the patient isn't in pain because their muscles are weak. You know, the patient doesn't have more pain because they're weak. But then why are we giving them exercises? Because they're coming to see us because they're in pain, right? No one walks through our door and goes, Mehmet, look, I really need your help. My gastrocnemius is really weak. Like, no one says that, right? Like, no one does that. Like, oh, my adductor longus is like super weak. Can you help me out? Like, they just come in and they're like, oh, it's my hip hurts or my Achilles hurts. And then we're trying to navigate like how to manage that. So there are links, though, when we look into the evidence. If you have someone who has adductor-related pain and they have a tendinopathy, for example, or is recovering from a tear, then we know that actually that there is a risk factor of having a weaker adductor group, or an asymmetry from adductor to abdominals can predispose to an adductor injury. So you're like, okay, we'll do kind of physical tests, wherever that might be, handheld testing or whatever. And you get some data, and then you try and treat the data that you're given to try and improve the symptoms by looking at the whole picture of that patient. In that respect, then you're giving exercises to strengthen specifically on the test that you've done. But then by saying, oh, you've just got back pain or hip pain because your glutes are switched up, when you've not tested it other than push against my hand, you're like, well, that's not really going to tell me anything other than the fact that you can just push against gravity and my hand. I can't really measure that. You know, that's Oxford scale measurement and stuff that you get taught is fairly redundant, low level stuff. So from that respect, I kind of like, it frustrates me. I kind of get sometimes how people try to use that information when sharing kind of stuff online or whatever it might be, or to patients, but it's so dated, you know, and all like, we even know now, you know, like think going back, you know, years, we used to kind of hammer like transverse abdominal like activation.
And that's still a thing in pelvic floor. That's still a thing in pelvic.
Everywhere.
Yeah.
None of it goes right. It doesn't matter how much you don't bend your back when you're picking things up. You think like, how much more can we like, you think we're moving away from it, but then it's still like there. It's quite frustrating. So I think often for patients, they don't care. I mean, often patients don't care about much of this stuff. It's just about like when they're trying to navigate it and look up information or listen to things. For every one podcast you and I do, there's going to be 15 podcasts or 20 podcasts of someone saying the opposite. And unfortunately, sometimes it's whoever shouts loudest gets heard, and then they kind of attribute that to, well, maybe they're talking the most sense, but that's not always the case. You're opening a can of worms, Susie.
I know I am. I have been looking forward to this conversation for a very long time, because like you, I also have my own inner monologue that goes on when I see such misinformation. Just, I think it really is a moral injustice. It's healthcare injustice to have this information circulating without having any fact checking, anyone to vouch for who is really are they really using up-to-date evidence, and leaving room for uncertainty, because a lot of what we're talking about is it has to do with uncertainty. Yes, it may not. Every individual is different, and every case should be individualized and tailored, as you're saying. So, there may be some things that are potentially the cause of that person's hip pain or pelvic pain, but there's also individuals who have data or diagnostic tests very similar to someone who's in pain who doesn't have symptoms, right? And that's where the uncertainty, we don't like uncertainty. Nobody likes uncertainty. We want to have the answers, we want to have the answers. So I think, as clinicians and also as people, as humans, it's embracing uncertainty, not waving the white flag and saying, okay, well, I'm not going to do anything about this, because that's not what we're saying here. What we're saying is maybe taking a bit more of a balanced perspective, and ultimately a biological, sensible approach that also has some science behind it.
Yes, times a million, basically, to everything that you've just said. I'd echo that. And you're far more articulate than I am, which is great. But with that kind of stuff, and I think often when I talk to clinicians who are younger and more kind of upcoming, there's always that immediate insight into, like, I have to know what's going on. I need to kind of say it's a rotator cuff problem. I have to say the problem with the hip is sometimes you kind of have to know there or thereabouts what it is that you're dealing with, because like there's a little bit more specificity to it. But also, like, you can never definitively say clinically, because even if you suspect pathology X is the problem, really you need more of an in-depth workup when it comes to the hip. Sometimes it even involves in diagnostic injections to really understand the painful source in some of these issues, and not everyone has access to that. So by like you said, embracing that ambiguity or uncertainty doesn't demonstrate a lack of understanding. Actually, it demonstrates more of an awareness of reality. So often when you're trying to teach someone that, you're like, well, it's fine. It doesn't mean go to the patient and pretend like you're completely unaware and like just say, look, actually, it could be this, it could be that. It's not going to change how we manage it. But if it's not improving, we can then look into it by doing this, this, and this. But unfortunately, patients want answers. They just want to say, what's the problem? What's the label? So you kind of have to appease them sometimes. But look, sometimes it is needed. It's just how you kind of manage it, I think.
Absolutely. And to your point about, what the data shows and exercises, I'd like to go back to that as far as talking about function, right? So we can strengthen or isolate a particular muscle and do exercises, but ultimately, I think in my point of view is how do we help them get back to the thing that they're wanting to get back to, whether it's a sport, whether it's going up and down the stairs, whether it's having sex, it's how do we get how function, right? Tying it back to the functionality of helping that person move better in their body with less pain and more confidence, really.
That's the thing, though. And I think, like, from my perspective, I think that's always, like, when I'm talking to individuals or whatever, like, sometimes that can be overlooked. The fear of coming across like you don't know specifically what you should be doing. And what I mean by that is when a patient is being told, look, we're going to do this exercise because if you do it, it's almost like that overcoaching situation again, where you're giving an exercise and you're giving them 100 bits of information because that exercise works muscle X. And actually, if you do it this way, it will kind of do this, that, and the other. Patients don't give a shit. They're just like, I just don't want to have pain. They don't care that like the adductor has multiple functions. They
Exactly.
just like, so when we're giving them stuff to do, though, like it's almost like you said, you've got a group of like tasks that you want to get back to, whether it's sport or not. And then our job is to try and we've got this goal here, we're here, and we're trying to think, well, how can I get to that? How can I bridge that gap with clinical reasoning of the exercises and treatment? It's not, I know people do manual therapy and stuff. So let's say clinical reasoning of the treatments that you're doing with this goal in mind. And then also the understanding of, well, look, sometimes it's going to be a bit like this as well. It's never going to be a direct, like linear, like improvement. So trying to kind of like get from one point to the other by doing those things is a tricky thing, really. But you just need to kind of like reason it Whereas sometimes where the downfall is when individuals are like, well, look, we're going to do your adductors because we do this, or like, and it just complicates matters further. Often if you have an athlete, sometimes that's needed. Like if the athlete's like, I need to get back to sprinting, and
Mm.
last time I muscle injury was when kicking or sprinting or change of direction, and you kind of have to manipulate that variable a bit more specifically. But
Mm-hmm.
if it's just general population and they're like, I want to go to CrossFit, I want to go to Pilates and
Mm-hmm.
yoga, and you just want to get them back to that point, they don't necessarily need to know your clinical reason. You need to know what you're doing, but you don't need to go crazy about telling them what it is, because they don't
Mm-hmm.
care. And
Right.
unfortunately, when you start going mad with it, and then you see that look right when they
Yeah.
glaze over,
Right.
and they're
Right.
like, "Oh, did you not hear about this article about like how if you load up your like blah blah blah?" And they're like, "Wow!" And you in your head, you're like, "Oh, I know so much," but in reality, they're like thinking about what they're having for dinner because they're
Right.
just like already.
Just tell me what I
So
need to do so I can go on
yeah,
with
you're
my day.
boring me. Go away. You're boring me. Leave me alone.
No, that's fair.
So that's
Exactly.
it's true though, and I think that's where patients obviously like often benefit, and it's interesting. So I'll give you an example. Like sometimes I'll have with my private caseload, I'll have patients who have had hip issues for years, like 2, 3, 4, 5 years, and have done tons of stuff. Often I'm like bottom of the pile, but it's just because they've only probably just found out about me and then want an appointment. So by that point, I've seen tons of people. There are so many instances where people immediately get, well, I say immediately, in the following months, improve quite quickly, having had it for so long, having just done the most simple stuff.
Mm.
Like, and they're so surprised that I get patients, because I sometimes will give a patient 4 exercises and they've had like millions of stuff. And I'm like, look, you've got 4 exercises, but I want you to do it as a circuit. I want it to be timed. These are the reps that I want you to do. These are the amount of reps and sets per week that I want you to do. I don't need to see you for 6 weeks. And all of a sudden they're like, okay, this is a bit worrying now because I've been going back in and out every day, well, every week to the chiropractor or whatever, like for ages. Now you give me only 4 exercises for 6 weeks. I'm like, yeah, but like also you are a biological human. Like, there's only so much that you can
Yes.
speed up these adaptation and changes. We can't do everything at the same time. And if I give someone like 7, 8, 9 exercises, it's boring. It takes too long. They're not going to stay compliant to it. It takes up too much time. And you're never going to be able to get as much out of all of those things. Whereas from my experience, if I give them 4, make it fairly tough and intense, clinically reason those 4, I know that if I talk to you in 4, 5 or 6 weeks, you've done maybe 18, 20, 24 blocks of that exercise. I know how many reps and sets you've done. And I know that actually we've done enough. Then I can move on to the next bit. And that shocks people sometimes because then they're like, oh, that's not enough. Like, surely I need to be doing more, or like, is there enough? But I'm like, look, that's just, if you're doing the simple stuff. And I tell them, I say, look, if you do the right things at the right time for the right amount, you'll see an improvement. I don't want you to come back, having had it for 5 years, I don't want you to come back in 4 weeks and expect it to have gone. If you do,
Mm-hmm.
then great. Please leave me a Google review. I'd love to. Please come back. It'd be great. But like, if you come back in 4 weeks and say it's not as bad, we're winning.
That's
Because
right.
if I give you a million, well, as I'll give you $1,000. See, I've put it in the right. I was going to say pounds, but $100, and I say go and invest in some shares. You're not going to look at that and think, oh, I just want it to go like this linear, direct increase. You'll think, oh, it's gone up a bit, it's gone down a bit. But if it's
Right.
going up over a period of 6 months, your quid's in. And rehab is similar to that. So if you're getting better slowly, then you're probably doing it right. And if you're having a bit of a setback, but the grand scheme is an improvement, you're probably doing it right.
Yeah. Yeah.
But if it's going backwards, it's quite clearly you're doing it wrong. But then even at that point, it's like, how long has it gone on wrong for? Because like I said, if you're having these little dips, that's not a regression. That's just part of it. That's just about saying, well, look, how can we manipulate the variables to then continue on that right trajectory? But if it's like the trend is like negative, 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 then we've got a problem.
Mm-hmm. We need to do
That makes
something
sense.
different. Yeah.
Yeah,
Yeah. No, that totally makes sense. And that's very wise advice as far as skillful recovery, and understanding that adaptation does happen, but it does happen over time. And like you said,
yeah.
with the right pacing, like the Goldilocks principle of not
Yes,
too much,
yeah, that's
too
true.
little, finding your sweet
Someone said,
zone.
"Oh, that's so interesting." Someone I interviewed someone this morning, and they said that. So, yeah,
Uh-huh.
see, it's twice I've heard that today. But that's true, though, right? It's just kind of again giving patient that is all about just a patient's self efficacy to self manage,
Right.
like their awareness, their education, and so much of that is vital, really.
Right, right. And being open to the trial and error process, right? If somebody hasn't been doing a particular activity or exercise in a very long time, for whatever, many reasons, obviously pain is one motivating factor for to avoiding things. You may do too much too soon, too quickly.
Mm,
That happens, and we don't freak out about that. We learn from that, right? It's if pain can change in that direction, then pain changes. That's really just
yeah,
proof that pain does change.
absolutely, absolutely, and that's just part of it. Like it's so complicated, right? It's just it'd be so much easier if it was just straightforward, but it isn't.
I
The more
wish.
you explain it to the patient, then it makes it easier, and also I just
Yeah.
feel like it helps that trust.
Yeah, absolutely. Absolutely. Oh my gosh, so many gems, no pun intended, because that is your last name.
Way, look at you! You're good at your
And
job.
it's
No
your
pun
last
intended. Don't lie.
name.
Don't lie. You wrote that down weeks ago. You wrote that
Did
down weeks ago.
yes, I was just waiting on the tip of my tongue. There is one topic because you mentioned the FAIS, femoral acetabular impingement syndrome, and hip dysplasia as potential reasons why someone might have hip issues. What is your knowledge around sports hernias or athletic pubalgia? It has several different names in the literature, but those are some of the con- I would say diagnoses that in the pelvic health world we may see, but often underdiagnosed or misdiagnosed, or just lacking of knowledge in that area because it is really tied to the pelvis, the hip, back.
Yeah, I
I mean,
think
it's a very
it's the trick. It's
complex.
very, very, and I think part of why, especially in sports medicine and hip and groin cohorts in particular, there is much more of a push towards like more of an umbrella terminology because it's so difficult to specifically identify causes. So obviously we've got it's almost like you've got hip, inguinal, pubic, adductor, and you we
Mhm.
kind of like, and even that, even when you've got something like with adductor where it's so much more common, we know kind of the muscle groups that are more prevalent, but even then you're like, well, there's other things that coexist with that, with pubic related pain, with inguinal related pain as well.
Mhm.
It kind of there's that overlap. The semantics of that for years was so confusing because
Yeah.
you had sportsman's hernia, Gilmore's groin, inguinal hernia, incipient hernia. Like there were so many
Mhm.
things. As a
Mhm.
clinician, that's why often there's like this real overwhelming feeling when you get someone who comes in with like we're talking like inguinal pubic pain because there is so much around that. And
Yeah.
even now when there's more research coming out in regards to like the PLAC, like pyramidalis ligament complex, like people still are even now finding out more causes that might be attributable to, especially those who have persistent groin and pubic pain.
Mhm.
Whenever I'm seeing a patient, whenever I'm teaching, there's such an, I'm not saying it's just because I'm on this podcast, but there is such a missed opportunity to utilize women's health and men's health specialists when it comes to this stuff. One of my go-to questions within my subjective now that I'm always asking, especially for female patients, is pregnancy, type of pregnancy, birth, number of births, because
Mm.
I know about the risk of prolapse and all those kind of things that might play a role, the role of pelvic floor muscles as well. But that's not me saying then I'll know the best way to manage it myself. I know my skill set, but then I know actually if there's something else that might be playing a role, we need to understand who to signpost to. And often those things, when I explain it when I'm teaching, people are like, why are you asking about that? Because you'd always consistently, if you don't really know much about that, it's like, oh, if you have SIJ pain, I'll ask you about like like the generic stuff. But actually, there's so much that like I wouldn't even know where to start learning when it comes to like deep pelvic floor stuff that plays such an important role. And even in men's health as well, where
Mm-hmm.
there's an overlap where you know things that have caught me off guard, you know, hyperactivity or pelvic floor muscles, you know, things that present with like also like accompanying neural type symptoms that masquerade as inguinal or like testicular pain from the hip, whatever it might be. You think actually there's a lot going on around there. So that's why when we're assessing it, it's a case of, well, look, systematically, let's try and refute. Is it the hip? No. Is it outside the hip? Let's try and look into that. And there are like the Doha agreement and the consensus around trying to identify the cues, the subjective and the physical ways that these would manifest. You know, the hip joint wouldn't give pain if you cough and sneeze. The adductor complex doesn't cause an issue if you do valsalve or a sit up, but might be uncomfortable because an abductor injury could coexist with an inguinal. And there's like, you know, the hip won't potentially could be a bit stiffer, but you wouldn't get that with an inguinal or pubic. So there's like subjective and physical cues that often, which I would refer to as USPs, like which is like a unique selling point. Like in business, you'd have a USP, like a unique thing, characteristic, or a pattern of how it would present. That if you start to identify those unique patterns, you can start to navigate it. But it's just, the difficulty is when it's like trying to be specific. And often that's when the imaging can be helpful, when you have like kind of trying to figure it out. Just another point on top of that, I'm trying to kind of give you like, I'm trying to talk and say a million things that's in my brain and trying to like articulate it and convey it smoothly. The other thing as well is often, especially in a young active athletic population, so many of these different structures, when they're problematic, will manifest with multiple different entities at the same time. So there'll be characteristics of it being inguinal, but they'll have some pubic related issues as well, even some adductor pain. So it's, although you're trying to like work through it and navigate one to the other, they also do overlap as well. And that's where like that pubalgia athletic type presentation can be somewhat overwhelming, but then the more that you see and the more that you understand, it kind of becomes a little bit more easier to manage.
Right. And so what I'm hearing is really that there's multiple different causes that could be contributing to having these symptoms. There's a cluster of symptoms essentially, and they're all unique and individualized as well for that individual. So taking the subjective and, you know, doing your objective data and testing, et cetera, and taking it into the whole picture. Essentially the same principles that we've been talking about as well for everything else, right? Like,
Yeah.
it's
And that's the thing. And then like you've then got like all the other stuff that you obviously would always want to just like kind of, if there's any inflammatory,
right.
visceral gynae related issues, always, if you're talking about someone who has inguinal related issues and, you know, aren't screening for potential gynecological risk factors or causes, familial history, all those kind of elements might overlap. So yeah, it's just about subjective for me is like the number one. I'd say you can kind of pretty much be on the right track with
Yeah.
a good solid subjective.
I agree wholeheartedly, definitely. One last question around this pubalgia or athletic pubalgia, or what is the term now? I mean,
I mean,
is there
pubic related groin pain, I'd say, within
okay,
pubic related
pubic
pain would
related
probably be.
groin pain. What does the literature say around surgery? Because this is a population that often is, again, like let's repair the abdominal wall, let's do hip surgery, et cetera, et cetera. And I do have quite a few of individuals that I've worked with who've had several surgeries around this issue.
Yeah,
What are your thoughts about?
it's a lot of it is down to the type of patient. I think if you're in elite sports, there's no time to waste. So whether it depends on what level of sport, but obviously if you're trying to get back as soon as possible, it's actually more difficult for a clinician like us to manage, because they're going to go and see an orthopedic consultant surgeon. You know, that orthopedic surgeon saying, well, look, this is potentially an issue, this, or, you know, may not be, but then they're kind of suggesting that. Equally similar with inguinal as well, if there's any potential like hernia that's not evident but still something that's being suggested to have surgery, the evidence is there to show that sometimes surgery can be beneficial. The difficulty is making sure that it's the right decision, especially I think with inguinal stuff as well. Often people can have surgery and get back and do quite well. You know, there's quite a kind of, there's a lot from a rehab perspective that we can do with pubic related and inguinal to get back post-operatively. But it's not something I really try and avoid it, to be honest. I really try and avoid it as much as possible, because there's so much that you can do without it. But the problem is, like, if you're then with an individual who's an elite athlete that's trying to get back to something as quick as possible, or even if they're younger and they're worried about risk of time off development, then you're like, well, do we have 6 months to trial it? Probably not. And then they go down the surgical route, but that's just sports, that's just elite sports of how it is. I wouldn't say it's my first port of call. Sometimes, sometimes it's needed, but yeah, certainly for pubic related issues, unless there is a distinct, we're talking like a rupture or something that needs repair, I would,
Right.
yeah, for sure, like, stay away from it, especially with things like, even if it's like a tendon tenotomy or something like that. I'd probably avoid it. You just, because you never know. You never know. That's the thing. You could kind of go and see the best surgeon in the world. You just never know how you're going to respond to it. So I would just say, kind of like trying to like offset it for as long as possible is, for me, my personal opinion. But I'm biased. If I was a surgeon, it will probably be the complete opposite. I'd be sitting there saying, operate on all of them, just surgically repair with a lot.
Yeah.
But it's just kind of experience, I guess.
Right. Exactly. Oh my goodness. So I have one more question for you, as far as, well, not a question, but maybe to summarize for our listeners and viewers out there. If your top 3 takeaways, or if somebody is struggling with hip pain, what are your top 3 pieces of advice for them?
First bit of advice would be go to www.thehipphysio.com. I'm joking.
Shameless plug. Don't you worry. We will have that in there. That will be the final question.
I think that the thing, like, I can't see, the thing is, I can't see everyone. And often, like, I think the number one thing would be, if you have persistent hip problems, find a decent hip specialist, physio, or sports medicine doctor who deals with it, because then you can rest assured that there'll be no bullshit. You can be rest assured that what you'll be told is the right thing for that. That would be my number one thing. My number 2 thing would be, don't be scared to move and exercise within what your hip allows you to do. Now, there are going to be certain things that people would probably listen to this and say, yeah, but you're telling me not to do 90/90s, or not telling me to do clamshells on your page. What? And then you're here saying number 2 is don't be scared to exercise. I never say those things to make someone scared. I'm just saying, if you've got hip pain, like, do things within reason that makes sense. And those things don't make sense for people who have persistent hip pain. Hence why I say don't do that. So I would always suggest trying to, focus on that. For the third point, I'd say, and a slightly different thing here, for a clinician listening to this, because no doubt you've got like patients and clinicians, I would say, if you're unsure on how to manage hip issues, because there is so much that's confusing and can be overwhelming, don't be scared to admit it. Don't wing it, because unfortunately the patients that don't do as well, that persist for so long, are often seeing individuals who are like giving advice or exercises or management or whatever that's with good intent, like well intended, but poorly clinically reasons. If you're unsure, just learn about it, seek support, reach out, ask questions, ask me, ask anyone, but just like kind of have a different approach to managing it cohesively with other people, so then you can get the right outcome for that patient. You asked for 3. There you go, there's 3.
Thank you, Mehmet. Those are beautiful. And now, shameless plug away.
Oh, there you go. Thank you very much.
Tell our listeners and viewers out there where they can connect with you, find you, and any other projects on the horizon that you have.
Oh, thank you. Well, so the social media is my main thing. So you can find me on Instagram or Twitter. So if you just type in the Hip Physio, you'll find me on that. My website's thehipphysio.com. So I see patients on Zoom. Majority of them are in America, coincidentally, and around Europe. So I do online consultations. And a lot of my work is teaching. So I teach do face-to-face courses and online courses. I don't have any in America, but I've got a ton in Europe where I go kind of and do a weekend course and teaching. So if there's anyone in America that wants me, or Canada, wherever, like, I'll come and do it. Just if you host me, I'll be there. Yes. But also, if you're a patient and you want help, my website. And if you just want some decent advice, go on my Instagram and see. And hopefully you don't get sick of me talking about hips. But look, you know what to expect. There's nothing else on there. It's just going to be hips. There's not going to be pictures of me like gallivanting around Dubai showing you what had for lunch, it's probably going to be not like I'm in Dubai having lunch often, but like I'm just give you anyway. The hip, in summary, Susie, the hip physio, and just you'll find me. In summary, all right, thank you.
And thank you, Mehmet. I love it. I love it. Yes. And I can vouch. I follow you on Instagram, and it is really good stuff. So if you do want to gain some quality knowledge and weed out the bullshit, please follow him. Mehmet, again, thank you so much for being on the show today, for your wisdom, your playfulness, and yeah, much respect to you and the work that you do.
Thank you. And yeah, thanks for having me. Time's flown by. So it was great. Thank you.
Thank you. And to all of our listeners and viewers out there, thanks so much for watching and listening. As always, and loving wellness for your pelvis. This is Dr. Susie G.